life is gonna be miserable until you figure out how to manage this. Let's talk about DKA. So it is a triad of hyperglycemia. This is a glucose greater than 250 milligrams per deciliter, ketosis, whether it's serum ketones or an elevated beta hydroxybutyrate, and an anion gap metabolic acidosis. This is a pH less than 7.3 or a bicarb less than 18. How is this made? Whether or not you have absolute or relative insulin deficiency, the cells can't use glucose, so they depend on lipolysis, which makes free fatty acids, which makes ketones, beta hydroxybutyrate, and acetoacetate, which leads to an acidosis. This causes an osmotic diuresis, leading to severe dehydration and electrolyte losses. You have counter-regulatory hormones, glucagon, catecholamines, and cortisol that amplify the process as well. DKA is most commonly triggered by infection, but it also can be from NMI, trauma, missed insulin doses, new onset diabetes, or steroid use. How do these patients present? Typically, they'll have polyuria, polydipsia, maybe even weight loss, nausea, vomiting, or abdominal pain. Classically, they'll have Kussmaul respirations, which are going to be deep and rapid. And then they might have fruity, acetone-like breath. They might be confused or lethargic, have altered mental status. The worst case scenario, if it's super severe, is that they would come in a coma. And then they might have some hypotension and tachycardia from the severe dehydration. So working this up, you want a point of care glucose, and usually it'll be greater than 250, but it can be normal in euglycemic DKA. So if they are on SGLT2 inhibitors or they're pregnant, get a BMP. They'll have a low sodium, but you'll have to correct for this. And then if they're in DKA, they'll have a low bicarb and a high potassium, but the total body potassium is depleted. You'll want a VBG, and this will show a pH less than 7.3, and this plus here, CMP will show you an anion gap metabolic acidosis. And then you want to get a serum beta hydroxybutyrate or urine ketones to prove that you are making these ketones, right? When people go into DKA, we want to ask why. So get a CBC, a lactate, maybe even blood cultures if an infection is suspected. Also get an EKG to look for signs of hyperkalemia and also ischemia. Let's manage these patients with just 6 steps. So first off, your ABCs, airway, breathing, circulation. If they're comatose, airway is priority, but honestly, you don't want to intubate these patients because those Kussmaul respirations are compensating for this metabolic acidosis. So let them kind of physiologically clear it. Place them on a monitor and get 2 large bore IVs. You want to keep them on cardiac monitoring with all of these electrolyte derangements, and you want to get serial glucoses and BMPs usually every 2 to 4 hours. Step number 2 is fluids. This is your number 1 priority once airway, breathing, and circulation are stable. Adults will get normal saline, sodium chloride usually, and this will be 1 to 1.5 liters in the first hour. And then you want to switch to 250 to 500 milliliters an hour based on their volume status and their corrected sodium. If you correct their sodium and it's high, switch to half normal saline. And then when their glucose is less than 200, you'll switch to D5, half normal saline, to avoid hypoglycemia while their acidosis is resolving. But really, those are your 2 branch points in when you're changing that fluid. These patients are often 5 to 7 liters volume down, so do not be shy with fluid resuscitation. And fluids alone can drop their glucose by 100 milligrams per deciliter per hour. So even if you're just starting fluids on them, you still want a glucose recheck in 2 to 4 hours. Step number 3, potassium. Even if their serum potassium is high initially, their total body potassium is depleted. And you want to replace this before you start insulin if their potassium is less than 3.3, because insulin drives potassium intracellularly and will drop it further, leading to possible arrhythmias. So less than 3.3, replace before insulin. If it's between 3.3 and 5, you want to start potassium chloride with fluids. And if their potassium is greater than 5, you don't need to replace it initially, but monitor it closely. Number 4, insulin. This is after fluids are started and potassium is greater than 3.